Good morning, everyone. I'm Dana Corson, a Senior Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you all for joining us this morning for a webinar on the report that was just released titled Medications for Opioid Use Disorder Save Lives. You can now download a copy of the report and other supporting materials at www.nationalacademies.org/OUD treatment. And you can follow the conversation about the report on social media at #OUD treatment. For those of you not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience and and serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report, but before I introduce them, I want to go over a few reminders. So please note that this webinar is scheduled to last 1 hour. We'll start off with a presentation summarizing the report by the committee members, and then we'll open it up to any questions you may have. Simply click the Q&A button at the bottom of your screen to submit a question. And also, the slides from today's webinar and the recording of the webinar will be available at that short URL. Again, that's www.nationalacademies.org/OUD treatment within about a week from this webinar. And if you have any technical issues, please contact Zoom technical support. I'm going to give you their phone number. That's 1-888-799-9666 and select option 2. Now I'd like to introduce the members of the committee that wrote the report who are here with us today. We have Alan Leshner, our committee chair, Chief Executive Officer Emeritus of the American Association for the Advancement of Science, and former director of the National Institute on Drug Abuse. Next, we have Colleen Barry, Fred and Julie Soper Professor and Chair of the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. Next, we have Walter Ginter, Project Director at Medication Assisted Recovery Support Statewide Network, and he is also a current patient on medication-based treatment. Next, we have Yasmin Hurd, Ward Coleman Chair of Translational Neuroscience and Director of the Addiction Institute of Mount Sinai. And last but not least, we have Scott Steiger, Associate Clinical Professor of Medicine and Psychiatry at University of California, San Francisco. And with that, I will turn it over to Dr. Leshner.
Well, hello, everybody, and thank you very much for joining us as we speak about this report from the National Academies that's concerned with one particular aspect of the opioid epidemic that's devastating this country and some other countries as well. Our focus was on, as this title slide shows, on medications that are used for the treatment of opioid use disorder, and you can see the bottom line of the report, that is that these are highly effective medications and in fact they save lives. Let's take a minute and speak about the context that we're operating under. There are greater than 2 million people who suffer from opioid addiction, from opioid use disorder. In a single year, 47,000 people died from an opioid overdose. Of course, there are other consequences, including the increased prevalence of other infectious diseases that are tied to opioid use. And then, of course, there are the side effects of this entire epidemic, not only socioeconomic for society, healthcare, loss of productivity, etc., but there's a tremendous impact, a personal impact on family members, the patients themselves, of course, but the family members as well. In response to this issue, the National Academies created this Committee on Medication-Assisted Treatment for Opioid Use Disorder. And let me just say at the outset that the committee, in its deliberations, decided that the term medication-assisted treatment is not appropriate and that we do not use that term in our report. The term we use is medication-based treatment. The medication is a treatment itself. It's not just a tool that you add on to treatment. And I'll come back to that point as we go on, but it should be clear that in spite of our title, we have renamed it. The study was sponsored by the National Institute on Drug Abuse at the National Institutes of Health and by the Substance Abuse and Mental Health Services Administration. As you may know, NIDA supports the majority of research on the health aspects of drug abuse and addiction actually in the world. SAMHSA is the major drug treatment service provider that's a part of the federal government. Committee had a very simple charge, actually, but a very limited charge. That is, first, review the current knowledge. What do we know and what do we not know about the effectiveness of medications for opioid use disorder? Secondly, how can those medications be effectively delivered, in what settings, and for what populations? Third, what are the challenges and the barriers to greater implementation and utilization of these medications? And fourth, identify additional research gaps. As you look through the report, you'll see that each of those points is covered rather explicitly. The research gaps, however, are sort of sprinkled through the report and aren't aggregated in any individual place. That'll force you to read the entire report in great detail. Okay, so the committee was actually one of the best that I've ever worked with the academies. Here's a listing. I'm sorry that it's hard to read because of the small type, but I can tell you that it's one of the most diverse committees that I've worked with. It brought expertise all the way from basic science through what you might think of as translational science, clinical science, people who are psychiatrists, psychologists, and uniquely, this committee included some people who are patients or have been patients suffering from opioid use disorder. It turned out that that perspective was particularly important, as of course what matters in dealing with this issue is to understand with whom we are in fact working. Okay, so the disorder itself, I should say that the term opioid use disorder is one that was invented by the American Psychiatric Association as a part of DSM-5. It's synonymous with what normal people would call opioid addiction. It's not just a tiny bit of opioid use, and I'm not going to go through it in too great detail. However, that first bullet is very important. It's characterized by compulsive, typically uncontrolled use of prescription or illicit opioids in the face of negative consequences. The in the face of negative consequences turns out to be an important criterion for understanding addiction, because there are lots of instances where people think they're using a substance or doing an act in an uncontrolled or compulsive way, when in fact there may be no consequences, but addiction is characterized by those consequences as well. It's caused by repeated opioid use, which results in changes in brain structure and function. We'll come back to that. In spite of the fact that it's a brain disease, a brain disorder, it in fact has behavioral and social contexts that are critically important both to its development and to its treatment and recovery. Finally, the purpose of the medications is to normalize brain structure and function, and that is in fact what we believe they are doing. The core message, the most important take-home message, is that these medications are effective. They're effective in treating opioid addiction. There are 3 FDA-approved medications, methadone, buprenorphine, and extended-release naltrexone, and they all are effective and save lives. What's important to know at this point is that, in fact, individual patients respond better to one or another. That is, that differential response can change over time. So, for example, whereas one medication may be most effective initially, which medication will be most effective can change over time. There are decades of evidence demonstrating that methadone and buprenorphine are effective and that they decrease the risk of all causes and opioid overdose related deaths. The database underlying extended release naltrexone is rather newer than the database underpinning methadone and buprenorphine, but we do know, and FDA approved it for this reason, that extended release naltrexone is effective. All 3 medications reduce opioid use and craving. A core point of our study is lamenting the fact that most people who could benefit from medications for opiate addiction don't receive them. Only 20% of people with opioid use disorder receive any type of treatment in a given year, and fewer receive medication-based treatment. Importantly, 5% of people who are incarcerated and suffer from opioid use disorder receive any medication treatment at all. I'm going to repeat that number. Only 5% of people who are under criminal justice control receive any medication treatment at all. And overall, only 6% of the drug abuse treatment facilities in this country offer all 3 medications. And I'm going to show you some dramatic maps that reflect this. If I can make it work, I did. Okay, so this is a map where the dark squares show you the distribution of substance use disorder facilities around the country. The darker the dot, obviously, the greater the number of facilities there are. And you can see that there are a lot of treatment facilities. There are places where there are serious gaps, places where formal treatment programs are not available, but there are a goodly number of them. This map, okay, remember that one. This map shows the facilities that offer offer any medications, that offer any medications at all for opioid use disorder, right? So you go from that to that, and this chart shows the facilities that offer all 3 medications. What that's telling us is that not only do the vast majority of patients who would benefit from medications not receive them, but the vast majority, very large majority of facilities that offer treatment don't offer all 3 of the FDA-approved medications. Why not? So these are the major barriers that are articulated in the report. I think everyone knows that there are very high levels of misunderstanding and stigma among both the public and the professional community about drug abuse and addiction generally, about drug abusers, about people who are addicted. And I can tell you that not only is there also a great deal of stigma surrounding drug treatment, but even the people who study the people who treat patients who suffer from these disorders. If I were to pick a single biggest problem, personally, I would pick this misunderstanding and stigma that keeps so many people from receiving the treatment they need. Professional education is not nearly at a level that we would like to see, not only for health professionals generally, but for people with expertise or whose job it is to treat substance abuse and addiction are inadequately educated. The regulations that currently exist restrict access to methadone and buprenorphine in ways that our committee believes are far too prohibitive, and that in part accounts for the fact that too many people who might provide these medications don't. And the fourth major barrier is the fragmented system of care and the current financing and payment policies that operate against wider use. Now, I'm going to go through the major conclusions of the report, and you'll see just sort of a bulleted major point. I'll expand on them with the narrative that in the report accompanies the conclusions, and I would urge you to have a look at that because you'll get the nuance far better than I'll be able to say. So the first conclusion is that opioid use disorder is a treatable chronic brain disease. It comes about because of the changes in brain structure and function that are caused over time by repeated opioid use. Although opioid use disorder is a brain disease, in fact, it has critically important behavioral and social context components to it, and those components need to be attended to in one way or another. Various people have varying degrees of social and behavioral consequences of their opioid use disorder, and therefore the amount of attention to those can vary. The purpose of the medications is to normalize brain structure and function. There are 3 FDA-approved medications, as I've said. Those medications are effective and they save lives. Because of that, the committee concluded that it's critical that all FDA-approved options be available for all people with opioid use disorder because of the individual differences in who will respond most effectively to which. We also make the point that at the same time as there are these medications, as with all medical conditions, continued research is needed to develop new and better medications, appropriate approaches and formulations so that we can expand the options. So we have these treatments available, and of course, we would like to have even better ones and a wider array. The third conclusion is an important one. I wish I knew the answer to what some will immediately think, and we don't have the answer. I'll get to that. But long-term retention on medications is associated with improved outcomes. People do better the longer they stay. The question people always ask is exactly how long do you have to stay on? Do you have to stay on for the rest of your life? I will say there are people who have been on medications for their entire lives, and they are highly functional people. However, we haven't had the long-term studies that would be necessary to do a better job of answering that question. The fourth conclusion is that a lack of availability of behavioral interventions is not sufficient justification to withhold these medications. There is a widespread misunderstanding that everybody who is suffering from opioid use disorder must have formal behavioral interventions as a part of their treatment modality. There are people who do need those interventions, but there also are people who do just fine only receiving these FDA-approved medications. Behavioral interventions can be very useful in helping engage people in treatment, in helping to retain them in treatment. However, they are not essential. And our conclusion is that if they are not available, that is not a sufficient justification to withhold treatment. The next one, most people who could benefit from medication-based treatment don't get it, as I said earlier, and access is uneven and inequitable across subgroups of the population. The report spends a substantial amount of time talking about the subpopulations of people suffering from opioid use disorders, and you will see as you look at that the discrepancies, the disparities are really terrible, and there are many vulnerable groups who receive virtually no treatment, and there is no treatment available. At the same time, medication-based treatment is effective across all treatment settings that have been studied to date. As I'm sure you all know, there are many different kinds of substance abuse treatment, sometimes in formal settings, sometimes in hospital settings or emergency rooms, or ostensibly in the criminal justice system. In every situation where it's been studied, medication-based treatment is effective and saves lives. Therefore, our conclusion, withholding or failing to have available all of the FDA-approved medications in any care or criminal justice setting is, in the judgment of the committee, denying appropriate medical treatment. And we believe that denying appropriate medical treatment is, in fact, unethical. There is no scientific evidence that justifies withholding medications from patients in any setting or denying access to social services like housing or income supports to individuals who are on medications. I'm sure, as the listeners know, there are settings where people on these medications are denied housing or denied access to social services, and there is no scientific justification for that. Finally, there are an array of barriers that are discussed in the report to the more widespread utilization of these medications, and those barriers have got to be confronted. And in the report, we highlight 4, but there are more than those 4. The 4 include the high level of misunderstanding and stigma that I referred to before. That stigma ascribes to addiction to individuals with opioid use disorder and to the medications used to treat it. Inadequate education of the professionals responsible for working with people with opioid use disorder, and that includes not only treatment providers, but law enforcement and other criminal justice personnel as well. The third barrier that I made reference to before are the regulations around methadone and buprenorphine. They include things like waiver policies, patient limits, restrictions on settings where the medications are available, and there is not a body of evidence that supports the need for those restrictions and regulation. And finally, the fragmented system of care for people for opioid use disorder. This is true of individuals in all vulnerable categories who suffer either from mental disorders and or from opioid use disorders, as well as impoverished people who in fact suffer from this fragmented system of care and the current financing and payment policies that would in fact be or should be available to provide that care. So these are the key messages that we hope you'll take out from this report. They're relatively simple and straightforward. Opioid use disorder is a treatable chronic brain disease, and it should be treated in that way. Medications for opioid use disorder are effective and save lives, and medications are not available to many people who need them, and denying access to them on any grounds that are not scientific, and as I said, there are no scientific grounds for denying that access, is denying appropriate medical treatment, and therefore, in the judgment of our committee, is unethical. We also, as we were asked, talked, as I said, throughout the report about some of the knowledge gaps and research needs. I won't spend a lot of time on that, but you can read as well as I can things like long-term head-to-head comparisons of the different approved medications, a better understanding of which behavioral interventions would be most beneficial for which patients under what circumstances, specific treatment guidelines for subpopulations of patients, as I said before, the development of new and better medications, and then there needs to be research to better understand how to drive real system-level changes so that we can increase access and use of these medications. Substances like methadone have been available for decades and decades, and yet very few of the people who need medication treatment receive it. Buprenorphine was approved around the turn of the century. Way too few people receive buprenorphine, and the same is true for naltrexone. The report is available at the website that you see there, and I hope that you will go and look at it. We, of course, wrote it, and therefore we think it's terrific, but it not only lays out the nature of the issues and the nature of the data, but does include some suggestions of how to go through it. So that's my part of the formal presentation. I am going to ask my four colleagues who have joined us by phone to each make some comments, and then we'll open it up to question and discussion. We'll start with Scott Steiger from the University of California at San Francisco. Scott?
I am speaking on behalf, or from the perspective of somebody who provides treatment for opioid use disorder in the context of both the specialty opiate treatment programs, or so-called methadone clinics, and I also provide it in the context of an office-based primary care setting. And it's with that perspective that I want to emphasize that as much as I might wish that the treatment for opioid use disorder was like a surgery where I could just do a quick fix and send people on their way, is something like a detox or rehab program that is conceived of as the proper treatment by many people. That's just not a rational approach for a chronic disease, and it's not supported by the data, as our report shows. You know, the risk of all-cause mortality among people who are in treatment on medication is reduced by about 70%. And, you know, as a primary care internist, I look at that and I say, well, that's about on the order of what providing prescriptions for blood pressure lowering medications does for people who have hypertension. So these are very effective medications, and they should be something that we deal with on the long term. The other point that I would just make is that because I am involved in a specialty treatment setting of opiate treatment program, most of the stuff that we reviewed in this article about effective adjuncts to treatment, that is to say, behavioral treatments for opioid use disorder, most of the stuff that we found robust evidence based for are not provided in opiate treatment programs because they're not mandated and because they are not compensated. So just as an example, we found overwhelming evidence that contingency management techniques improve retention and treatment and decrease non-opioid drug use, but these are very randomly employed and rarely employed by drug treatment programs. Lastly, as a specialist in this, a practicing specialist, I just want to point out that not everybody does great on the medications that are available. And so I would really like to see research that expands the toolkit of medications that are available for treatment because many of my patients need more help than I can give them.
Good. Thank you very much, Dr. Steiger. Walter Ginter from the Medication Assisted Recovery Support Network.
Hi, am I on? Thank you, Alan. Thank you, Scott. And my name is Walter Ginter, and I'm speaking from the perspective, as Scott would say, of someone who has been a patient on medication-assisted, medication-based treatments for, perhaps 40 years on and off. And as someone who provides peer recovery support services to people who are trying to recover from opioid use dependence. Well, let me say first how honored I am that the National Academy of Sciences, Engineering, and Medicine, including me in this committee. Alan mentioned that it's not often that that they get down to the level of actually including the people involved, and I'm very proud to be that person. I'm sure the National Academies wanted a perspective of someone's recovery from opioid use disorder had been successful because of medication, and as I said, I'm glad it was me. I first entered medication-based treatment in 1977, and I'm an example of the report's title: Medications for Opioid Use Disorder Save Lives. It's hard for me to envision a way in which I would still be alive if not for medication. Seriously, I mean, I first went into treatment in 1977, which was a long time ago. I wasn't in treatment continually. I did taper several times along the way, but the fact of the matter is, if not for medication, I would be dead. Now, as a patient and medication-based recovery advocate, I also support the report's conclusion that medication should not be denied because behavioral interventions aren't available. However, as a person who has spent the last 14 years providing peer services in partnership with a full-service treatment provider, one who provides all three of those medications, I know that medication alone isn't always enough. In many cases, patients do better when provided a full array of behavioral supports in conjunction with all three of the medications. Lastly, and this is not going to be a surprise to anyone, the burden of regulatory compliance directly affects patients and patients greatly. When I ask patients leaving medication-based treatment if they would stay, if they could get their methadone from an office-based provider as I do, they always say yes. We have to reduce the regulatory burdens in clinics and simplify or eliminate that 2000 waiver process if we want to reach all the people in need. And most importantly, reach the people in need and keep them in treatment, because we know the longer a person stays in treatment, the better they do. Thank you.
Thank you very much, Mr. Ginter. Colleen Barry from the Johns Hopkins Bloomberg School of Public Health.
As Dr. Leshner noted, a charge of our committee was to identify the major barriers to use of medication to treat opiate use disorder. We identified, as has been said, stigma and misunderstanding about both opiate use disorder and about these life-saving medications as important barriers to broader access. Stigma involves labeling, stereotyping, and linking individuals with addiction to undesirable characteristics that lead them to experience status loss and discrimination. And research indicates very high levels of stigma, not only among the general public, but within key professions, including medicine, public safety, criminal justice, housing, child welfare, among others. And stigma has been shown to have detrimental effects on psychological well-being and can prevent treatment seeking. Other barriers we identified in research include critical gaps, as has been said, in professional education. Here again, the strong need for more robust education and training extends throughout the medical care sector, but also beyond it. Our committee identified system fragmentation, in particular the lack of integration of the specialty substance use treatment sector with the broader medical care sector as a major barrier. The report discussed inadequate insurance and financing as a barrier, and our committee noted the promise of recent insurance expansions and value-oriented payment systems approaches for increasing access to medication treatment. Finally, our committee identified regulations limiting the settings and contexts in which buprenorphine and methadone can be offered in the absence of evidence.
Colleen, we just lost you. Can you repeat what you said? Okay, I'm going to just move on. I'm sorry, Dr. Barry. She was making an important point about the absence of any evidence justifying the super regulations surrounding methadone and buprenorphine. Let's turn to Dr. Yasmin Hurd from the Icahn School of Medicine at Mount Sinai.
Hi, and thanks everyone for coming in to listen to this webinar. So I'm the director of head of the Addiction Institute, and my perspective is based on two parts. One, it's the fact that our institute is one of the largest opioid treatment programs in the country, with approximately 6,500 people who come to us with about 1.1 million visits per year. So we have to maintain opioid treatment program mainly on methadone and buprenorphine, and it does work. But it tells us we have 6,500 people. So as a neuroscientist, for me, along with a lot of researchers in the US and internationally, we know that addiction is a chronic brain disorder. And it's important to combine the clinical work and the research enterprise to really provide evidence-based treatment and to develop potentially new medications to save the lives of our patients. So as Dr. Leshner and Dr. Seeker articulated, it is clear that the current FDA-approved medications work, but we need to reinforce them with continued research. We need to enhance the care of all individuals suffering from opioid use disorder. And this includes understanding the functional outcomes of medications for opioid use disorders. There are very few studies that actually have looked at the global functioning of people on these medications. Additionally, obtaining real-world evidence on patient preferences. There are clear individual differences, and we don't understand them enough because not enough research is being done on that. We also need to expand the number of opioid use disorder treatment medications by targeting other neural systems than only the mu opioid receptors where methadone and buprenorphine and naltrexone target. So those systems that are really related to craving. And while they're in their infancies, things such as anti-opioid vaccines, the cannabinoids, and a number of other systems are being looked at, but they're still in their infancy. So robust research is really necessary to expand that medication toolbox to help clinicians and to help patients and their families.
Good. Thank you very much, Dr. Hurd. So I think we'll now open up the floor to questions, and Dana will read them, and I will either answer them or ask one of my colleagues. And if one of my colleagues wants to expand on whatever I said, please feel free to do that. So, Dana.
Thanks, everyone, for your presentation and comments. We're now moving into our Q&A session. As a reminder, please click the Q&A button at the bottom of your screen to type in a question. So first off, can you provide further comment on the change in nomenclature to medication-based treatment?
I can. The issue is whether one views medication as an essential part of the treatment portfolio or whether one sees it as simply an add-on that makes things a little bit better. And in English, the term medication assisted implies that everybody must have something else, and then adding medication just makes it a little bit better. Well, the truth is, medication is a core treatment. It's a core treatment, we believe, for virtually everyone. That doesn't mean some people don't get better without medication, but it's very difficult. And therefore, medication is a core element of treatment and therefore should be thought of as either just medication treatment or medication-based treatment to which you would add other things.
Thank you. Next question is sort of a two-parter. Why does the FDA require a waiver for treating OUD? And then why does CMS stop eligibility for Medicaid when a person is incarcerated? The comment with that, this reduces options for counties to implement buprenorphine / medication-based treatment while an OUD prisoner is in prison.
Okay, well, we don't think there's a scientific basis that's underpinning the requirements for waivers. The waivers were put into place because people felt that medical professionals had inadequate education, and that still is true in some cases, but there is no scientific evidence that justifies an extensive waiver system. And I'm going to ask Dr. Steiger if he wants to comment on that afterwards. So the issue from my perspective, but I'm going to ask Dr. Barry to comment on this as well. Hopefully she's reconnected. In the case of cutting off reimbursement while people are under criminal justice control, my position would be that that makes no scientific sense. Why would we want to withdraw treatment from people in any setting? We certainly wouldn't do that with blood pressure medication or diabetes medication or statins. Why would we single out these medications? So, Dr. Steiger, do you want to say anything about the waiver business?
Yeah, I mean, the point that the writer makes is that you can, providers can write for the opioids that cause opioid use disorder, but not the ones that treat it, which is kind of backwards. I think that there is a nascent movement to make the treatment of opioid use disorder a fundamental part of nurse practitioner and medical students' education before they go into practice. It's very, very early days for that, but the idea would be that it becomes part of the regular part of medical training, so that then when people are in practice, rather, they feel comfortable treating opioid use disorder.
Okay, Dr. Barry, do you want to comment on the second part of the question?
Yeah, I'd be happy to comment. So I agree, Alan, with your point that there is no medical justification for terminating coverage. What ends up being extremely problematic is that when Medicaid is terminated, when someone is incarcerated, when that individual is released, it often takes months to reestablish Medicaid coverage, and that treatment gap can be devastating, in particular given what we know about extremely high rates of overdose in the context of the period directly following release. What many states have been doing is to pass suspension policies. So instead of terminating, Medicaid coverage is suspended. And these kinds of policies have a lot of promise for improving continuity of care. But as the report notes, one of the most critical things is to be able to allow individuals to continue receiving treatment or be initiated on treatment when they are in criminal justice settings.
Great, thank you very much. Next.
Thank you. Next question, should incarcerated people with OUD have all forms of medication-based treatment available to them?
Yes, that's the easiest question to answer. There is no scientific justification for withholding medications or not making all three medications available while people are under criminal justice control. There is nothing that scientifically justifies that, and from a medical perspective, there's nothing that justifies that. Therefore, we would hope and expect that the criminal justice system would take this issue up in a very serious way and address it.
Thank you. Next question. Once a person is on stable treatment, can you comment on the use of these medications in working populations, including in safety-sensitive work?
My answer is they're fine. But let me ask Dr. Steiger, who's a clinician, and then I would like Walter Ginter to comment on it because he has personal experience. So, Scott, do you want to go first?
Yeah, sure. When somebody is properly dosed on either buprenorphine or methadone, they do not suffer any kind of cognitive sedation or anything that would make one concerned for their or somebody else's safety. The evidence for long-term cognitive effects is limited, but it suggests that people actually, compared to other people, people on treatment compared to people who are not on treatment, have at least as good a function. And so I don't think that there's any solid evidence base for me to say, yeah, everybody can work at any job. It'll have to be an individualized decision, but there's no evidence that they should be prohibited from any particular position.
Oh,
I didn't hear you.
I'm
yeah,
sorry. Hi. As far as I really can't speak for for me and patients in treatment, but I can speak for myself. I've been on medication pretty much continually since 1977. In that time, for the first 25 years, I built a human resources company that at one point supported up to 15 people. Eventually, when we left that business, I wrote federal grants. I supervised federal grants in amounts of almost $6 million at this point. For the last 14 years, I've been director of a project that provides peer services to people who are on medication. I think that as far as that's concerned, as a patient, I can do with what anybody else concerned. I don't know that I could practice surgery, but I haven't gone to medical school. But, within the limitations, I can do anything anybody else can do.
Thank you. That's very, very helpful. Next question, please.
Thank you. Next question is, do you think methadone should be distributed not just in clinics, but also in places like CVS or Walgreens?
So I'm not a clinician, and therefore I don't think I should be answering that, but I will ask Scott Steiger to answer, and he can reflect the view of the committee as well. Scott?
Yeah, I think our committee was reluctant to make treatment recommendations. I would just observe that, in the report we point out that in other countries, pharmacists are intimately involved in the treatment of opioid use disorder and do distribute methadone for the treatment of opioid use disorder. There are models for it taking place even within the United States, but they're very, very limited in terms of where those are, and they require a lot of extra work to receive the appropriate sort of blessing or waivers from regulatory agencies. And so from a scientific perspective, I would say the evidence is pretty clear that it can be done safely. How to do it and exactly the right approach, we didn't weigh in on.
Can I add something to that, Alan? Can I add something to that? Yeah, this is Walter. I'm on office-based treatment, which means that I don't go to a clinic, and that's not a problem for me, and it's not a problem for any of the patients. In New York, where I live, we've had medication prescribed at pharmacies and things like that, but always in conjunction with a medical provider. And the reason for that is, unfortunately, of all the three medications, methadone is the most unforgiving. And the truth of the matter is, it really needs to be supervised by a medical provider. I mean, I have no objection to actually being prescribed, and distributed at a pharmacy instead of an OTP. That's a great idea. But I think it has to be prescribed actually by a medical provider.
I think we would all agree that no medication should be, prescribed by someone who isn't a health professional. And in these cases, we have a variety of health professionals who are eligible to provide it. We just don't have enough of them. Okay, next question, please.
Yes, we're getting a lot of questions about different groups of people and that we've looked at. So have you looked at data by gender, age, and socioeconomic status? Are there implications of these differences?
So the report does talk about a variety of populations individually and talks about the database that's available. But in conclusion, the medications are effective for all of them. Having said that, it would be great to have a larger body of evidence, a larger body of research looking at if there are individualized needs for individualized populations. For example, some may need behavioral treatment associated with it or not. And we just don't have enough research. There are great disparities among populations, but the evidence that exists does support the conclusion that these medications are effective for all of the subpopulations. I don't know if any of my colleagues want to add anything to that. No. Next.
Okay. Next question. Given that 94% of physicians have not taken the 8-hour data waiver course required to prescribe buprenorphine, and the fact that nearly half of the counties in the country have no buprenorphine prescriber, what can you say about a strategy of requiring trainees, so medical, nurse practitioner, physician assistant, students, and residents, to complete the data waiver training during their overall training?
So I'll let my colleagues expand on this, but my position is I don't know that the waiver training per se is the best of all training. Having said that, I do believe that given the magnitude of this crisis and the very high prevalence of addiction generally, it's my view that every medical professional, whether they're a physician, a psychologist, a nurse practitioner, you pick it, that every medical professional should receive training in addiction and in the treatment of addiction. Anybody want to add to that?
I mean, this is Scott. I would just say that I think that I agree with Alan, and I think that what this question points out is that this strategy would be completely inadequate right? If what we want to do is something right now instead of expand access to treatment right now rather than in 10 years when those other counties, when those those nurse practitioners and those PAs and those doctors are out in practice, that's sort of the long-term strategy. A shorter-term strategy would have to be something along the lines of mandating that people do the training earlier, people who are in practice do the training earlier, or just getting rid of the waiver completely. Because again, we don't have any scientific evidence that results in better treatment for individual patients.
Alan, this is Colleen. I want to say something too.
Please.
And that is that we know from research that just going through the waiver process is not enough. Many individuals who are currently waivered either don't see patients at all or see a very small panel of patients with opioid use disorder. And so I think if we continue with a wavering strategy, which I think our committee found an absence of evidence supporting. But if we do, then much more attention needs to be paid to educating providers who've been waivered, to supporting them, to teaming them up with individuals who have extensive experience to give them the backup and support they need, and critically to address the issues related to stigma and misperceptions that serve as a barrier to individuals, even if they're waivered, feeling comfortable having large panels of individuals with opiate use disorder treating them with medication.
Thank you. Next question, can you speak to the role of counseling and close monitoring by the prescriber, that is standard medical management or physician management, in the effectiveness of medication for opioid use disorder? In other words, do we really know how effective medication alone is without closer follow-up than is usual in primary care?
So in no medical setting and for no disorder would you just throw medicine at somebody. That is to say, we always recommend medical management, particularly for chronic disorders. So take diabetes, blood pressure, even high cholesterol. We want people to monitor their issue. We want them to account for their compliance. We want physicians and other health professionals to discuss with the patients not only the disorder, but the treatment for it. So medical management should be the norm. The question is not whether you need medical management. The question is whether you need more for everybody. And in our judgment, you need more for some people, but not for everybody. And therefore, the lack of availability of formalized more, or that is to say, formalized behavioral treatment or counseling, is not justification to withhold those medications. Again, anybody want to comment on that?
This is Yasmin here. Completely agree, and this is one of the issues that our committee discussed, the integration into primary care and having it extended to many more physicians. A lot of times, for example, in our opioid treatment programs, they're separated physically from even primary care for a number of clinics, and that's correct from a lot of places in the U.S. So the fact that we have so few physicians also who are waivered in rural communities is a huge issue. So it is about having access to all medical care when you have a chronic disorder.
Thank you. And so we're about at the hour mark. So it looks like those are all the questions we have time for today. Once you exit this webinar, you will be redirected to our report page, and that again is www.nationalacademies.org/OUD treatment. The webinar slides and a recording of the webinar, again, will be available there within about a week. The report and other supporting materials are available from that page right now. So with that, I'd like to thank all of our speakers and thank you all for participating today.
Thank you.
Thank you.
Thanks, everyone. Bye.